All right, let's get right into it. We're going to follow a patient's journey through what is one of the most systematic and honestly impressive processes in modern medicine, diagnosing and treating breast cancer. And it all kicks off not with some fancy machine, but with a person's own words. So, this is where it all begins. A 56-year-old woman walks into a clinic and says this: lump and pain in the left breast for over 1.5 months. And that one sentence, believe it or not, it's the starting gun for this whole cascade of investigation that we're going to follow, step by meticulous step. And right out of the gate, there's a reason for alarm. The patient says she first noticed this thing about 6 weeks ago. Back then, it was about 2 by 2 centimeters, but today, it's a whopping 7 by 5 centimeters. So it's not just a lump, it's a lump that has nearly tripled in size. And that speed, that rapid growth, really shapes everything that's about to happen next. And that brings us to our first part, a lump. A question. We're moving from that very personal initial discovery into the clinic where the real questions start to get asked. Okay, on to part 2, the clinical detective work. You know, before any high-tech scans, before any lab tests, the whole process begins with something much more fundamental. It's about doctors using their hands and their eyes to do some real old-school detective work. And this is fascinating because each one of these findings is a clue that tells a story. The doctor finds a lump that's hard and has irregular edges, not smooth, that's a big one. They can actually see that the nipple is being pulled inward, the skin is tethered, which is a great word for it. Something underneath is pulling it down. And they can feel a single swollen lymph node in the armpit. You see? These aren't just random observations. They are classic puzzle pieces that are already starting to form a very specific picture. So you've got these initial suspicions, right? But how do you go from a strong hunch to a concrete answer? Well, that takes us to part 3, getting the full picture. For that, medicine relies on a gold standard process called the triple assessment. Think of it like a 3-legged stool. The diagnosis rests on these 3 pillars. You've got the clinical exam we just talked about, then you've got imaging to see what's happening inside, and finally, the tissue sample to get the absolute confirmation. If you take away any one of those legs, the whole thing falls apart. You need all 3 for a stable, rock-solid diagnosis. So, leg number 1, the physical exam, is done. What about the second leg? What can a picture actually show you that your hands can't? And this is so key, it's usually not a choice between one or the other, they're a team. A mammogram is fantastic for spotting these teeny tiny calcium specks, which can be a super early sign of trouble. But an ultrasound is the champion at figuring out if a lump is solid or just a harmless fluid-filled cyst. Plus, it gives you the best close-up look at those lymph nodes. They work together, each one filling in the other's blind spots. Okay, so the exam is suspicious, the images are suspicious, but we're still not at 100% certainty. How do doctors get to that final, definitive, no doubt about it answer? And that's where the third leg of our stool comes in, the core needle biopsy. Now, it might sound a little intimidating, but the concept is really straightforward. A doctor uses a thin, hollow needle, usually guided by an ultrasound so they can see exactly where they're going, and they take a few tiny little samples of tissue right from the lump. Those samples go to the lab, and that gives you the ground truth. That's the final answer. So once the diagnosis is confirmed, the mission completely changes. And that brings us to part 4, decoding the cancer's blueprint. It's no longer a question of if it's cancer. It's now about understanding everything about this specific cancer, where it is, what type it is, and what's making it tick. The first part of that blueprint is just figuring out the lay of the land. It's called staging, and doctors use this system called TNM. Now, it looks technical, but it's really just a simple map. T is for the size of the tumor, N is for nodes, has it spread to the lymph nodes, and M is for metastasis, has it traveled to distant parts of the body. For our patient, the stage is T3N1M0. In plain English, that means a large tumor, 1 lymph node involved, but no sign that it's spread anywhere else. But here's the thing. Staging is just the geography of the cancer. To really fight it effectively in the modern era, you need to know its molecular personality. You need to understand the biological signals that are actually fueling its growth. Because breast cancer isn't just one disease, right? It's a whole family of diseases. So that biopsy tissue gets tested for special receptors, things like estrogen, progesterone, and a protein called HER2.
This patient's cancer turns out to be hormone receptor positive and HER2 negative, which gives it a specific name, luminal A. And knowing that subtype is the absolute key that unlocks the door to the most effective targeted treatment.
So all of this amazing information comes together in our final section, Part 5, Crafting a Treatment Plan. Every bit of that detective work, the exam, the images, the biopsy, the blueprint, it all leads right here to building a personalized strategy for this one patient.
A core idea that guides modern treatment is something called the spectrum concept. What it means is that doctors see cancer as two things at once. It's a local disease, the lump you can see, but it's also a potential systemic disease from the very beginning. Tiny cells might have already escaped. So the treatment plan has to attack on both of those fronts. And that's why the treatment path today often starts with a step you might not expect. Instead of rushing to surgery, step 1 is often pre-surgical or neoadjuvant therapy. They'll use chemotherapy or hormone therapy first. And this is genius for 2 reasons. 1, it can shrink the tumor, which makes the surgery itself easier and more effective. And 2, and this is huge, it's a real-time test. The doctors get to see if the drugs they've chosen are actually working. Then comes the surgery, and finally, post-surgical therapy to mop up any stray cells that might be left.
And when we talk about the surgery itself, this quote from a senior surgeon is so important. The choice between, say, a mastectomy or a smaller breast-conserving surgery isn't just a medical calculation. It's a shared decision-making. It's a true conversation, a partnership that puts the patient's own values and goals right at the center of the plan.
So when you trace this journey from a simple lump to this incredibly precise, personalized plan, you realize it's more than just one person's story. It's really a testament to this systematic, powerful search for answers. And it makes you wonder, right? As our ability to read that cancer blueprint gets even more detailed, how is that going to redefine this fight for the next generation?